Good morning, everybody. We're about to start this Health Systems Global session titled What Works to Amplify Community Voice and Address Power Inequalities or Corruption. This is going to be a very exciting session. It's been pulled together from a number of different abstracts, all people working on community and community accountability and engagement. We have a really great panel who I'm going to introduce just before each of their PowerPoints. My name is Jill Olivier. I'm at the University of Cape Town, and I'm going to be chairing this session. We really encourage you to put any questions you have into the Q&A section while the presentations are busy being made. We know sometimes you forget when something else interesting comes up, so please put the Q&As up, and we will have a general question and discussion session, more substantial session towards the end. If you have any other comments or you want to share your own experiences or other ideas, please put those into the discussion forum. Just something to comment on. This group, the panelists are wonderfully people all that have great experience and are living and working in LMIC contexts. We have panelists from Uganda, Bangladesh, Kenya, Malawi, one currently very early in the morning in Canada, but has done extensive work in Lebanon and the regional areas. And so just as a point of just clarity, there are some challenges with internet connections in some of those sectors. It is just a reality of the world we all live and work in the global south and in those areas. So we're going to do our best to work around those, and the panelists are all awake and they are here with us, and they're looking forward to the discussion, especially towards the end of the program. But just to have some patience and forbearance with some technical challenges that might occur, and just take them as part of the real life experiences of working with communities and working in local settings. So therefore, without further ado, I'm going to start by introducing the first panel presentation. And then we'll move from there, and if the others will just bear with me, I'll introduce them just before, as we're changing over to the next set of presentations. So the first panel that we have, the first presentation that we have is Mr. Noel Namahani, and he's a research officer at Makerere University in Uganda in the School of Public Health. Noel has a MPH, Master's degree in Public Health, and he's a research officer at Makerere in the school, and he has a lot of varied research interests and experiences in health systems and health policy. So without further ado, I'm going to suggest that we move over onto the first presentation. Great.
Oh, yes. Thank you so much, whoever is watching this and listening to this. Let me also welcome you to this yet another exciting symposium on reimagining health systems. My name is Noel Namahani from the School of Public Health, Makerere University, Uganda. And I'm here to present to you the work we've been doing in the past 12 months. We're trying to strengthen community health systems to generate demand, accountability, and utilization of sexual and gender-based violences in Eastern Uganda. Sexual and gender-based violence, SGBV, remains a big problem. 10 women, 4 of them have experienced some form of sexual gender-based violence. And of course, this is coupled with low levels of reporting, limited access to services, and then of course, this comes as due to corruption levels at the point of access. Patients, survivors asked for money, which are not supposed to be paid. And of course, the non-responsive systems, the survivors don't receive the services from the facilities. Of course, also there's an issue of misuse of power, as those people who are in power turn to perpetrators. Those are the police, the local council leaders, they tend to be perpetrators. So what we came up with an intervention, a community-based intervention. It's more of a community health club. We formed community health clubs in 4 villages, and then we empowered these clubs. Clubs composed of about 20 members, and then we trained them on how to offer services, and then also on how to sit and come up with solutions as the community. So these clubs, they were doing a lot of things, creating awareness in the community, linking the survivors to services, also reporting SGBV cases, and also they were facilitating what we call a community scorecard, whereby they sit and then they come up with the kind of a report on where they are, depending on the number of indicators they have come up with. And then also they facilitate dialogues between the community members and then the service providers. So one of our objectives was to evaluate the effect of this intervention. And in there, we used a Quest experimental study. Now, when we look at the effect our intervention had on reporting, we see that looking at the baseline, midline, and then end line, we find that there's an increasing number of survivors coming out to speak about SGBV cases. It increased, for example, at the baseline, we had the blue signifies the intervention, and then the orange is the control. But at the baseline, you find that only 23% were coming out to speak about this. But at the end of the project, you find that 46.7 were coming out to speak. Though between the control and the intervention, we are not seeing statistical differences between those two arms. When you look at the cases have gradually declined. When we did the baseline, the prevalence of SGBV, someone experiencing some form of sexual gender-based violence, we find that 41.7% had experienced in the past 6 months. But at the end of the intervention, we see that we have 29.9. However, also, we don't see significant differences between the intervention and the control. And this basically may be due to the short project. We've had only 1 year to do this, but also the COVID came in there. So it affected some of our indicators. Looking at access to services, you find that at the baseline, only 12.6% of the survivors were accessing, SGBV services, and going to police and receiving services, health services. So at the end of the day, we have 22.3%, over 80% increment in access to services. However, and in the intervention arm, we see that slightly higher proportion of those who receive services compared to the control, though there's no significant association between the two. Now, we also had what we call the scorecard implementation, whereby we had the community, the club sitting with the community members, trying to score, ranking where they are in terms of some of the indicators. For example, access to services, awareness on SGBV, the SGBV cases. So they could sit and then they score. And then also the service providers could sit and then they score. Then at the end of the day, we have a dialogue between the service providers and then the community. So this is our scorecard. So far we have had 2 rounds of scoring. We have 1 more scoring at the end of this month that is going to the end of this month. But as you can see, look at this scorecard, we have a number of indicators. As you can see that this scorecard is more of a qualitative kind of tool that looks at how are you faring on a number of indicators as scored by the community members and then as by the service providers. So as you can see in round 1 at the start of the project, whenever you see red meaning we are doing badly in that indicator, yellow fairly, and then the green is the good, it's the desired outcome. So you find that we have a lot of red and yellow at the start, and then at the end, in round 2, midway, we have green here, meaning we have had some improvement. For example, the number of people coming out to report, in many villages, it was just average, and in some it was red. But now we see that we are having green all throughout. So this just gives us an indicator that, the project has tried to improve in terms of reporting, utilization of services, the knowledge on sexual and gender-based violence, the attitudes have tried to improve. So still qualitatively, the service providers have reported an increase in utilization of services compared to before. Also, the community members, looking at the FGDs we have done, they report, police and health workers are now more responsive to the survivors compared to before. I think this is because they are now more accountable. And then also the incidents of, those being in power being perpetrators, the chairman, and then the police, becoming the perpetrators of SGBV have reduced. The reported instances have reduced. But then also, community members have reported a reduction in the corruption at the service delivery centers. So in conclusion, as we wind up this, as we are trying to reimagine a health system that works for everyone, a health system that, is more responsive, that responds to the needs of the community, a community health system remains a critical component. We need to engage, strengthen this community system. Our communities have a number of opportunities that we can tap into. The number of organizations, number of groups, saving groups, those we can use, we can tap into them and empower them to see that they check on the mainstream health systems. And also another thing we see that fostering dialogues between the community and service providers, strengthens the linkage between the community health system and the mainstream, system. So that in a way, the community can check on the mainstream health systems. And in there, which we achieve accountability, we achieve responsiveness, and issues of corruption, can go down. Thank you so much.
Thank you, Noel. That was great, and thank you for the introduction that you recorded in there as well. That gave a better sense of who you are. We're going to leave the more detailed questions for Noel later in the discussion, and I hope that you all start thinking of putting them in there. I've taken a look at the attendee list, and I see many colleagues in the attendees who are also very experienced in working on these particular mechanisms, things like community accountability and scorecard. So it would be great to get some of your experiences as well. I put a small poll up, which just basically asks, has anyone else ever found community scorecards to be useful to amplify community voice in your settings? I'll leave it up for a few more minutes as we change over onto the next presenter. So if you have an opinion, you can say yes, no, or it's difficult if you want to vote. And then I'll put another question up, another poll up for the next presenter. So the next presenter then is Ms. Nazrat Khan, who has a lot of experience working in varied different areas, mainly in Bangladesh. My understanding is that Nazrat she calls herself a practitioner of development communications, and especially in health policy issues and policy advance. She's had experience as a journalist, she's worked at international NGOs, and she's currently at BRAC University at the moment. Nusrat's going to be speaking specifically about health dialogue for citizens and thinking about effective public engagement tools to improve health services in hard-to-reach areas in Bangladesh. So we're looking forward to Nusrat's presentation. There we go.
Hi everyone, I'm Nazrat Khan and I'm now presenting a presentation titled by Health Dialogue for Citizens, an effective public engagement tool to improve health service in hard to reach areas in Bangladesh. My co-authors are KM Saifur Rahman, Shuhana Shafi, Shahid Hussain and Iqbal Anwar. First of all, I like to focus on Health Dialogue for Citizens. This is a public engagement tool which has been used in hard-to-reach area in Bangladesh to improve the health service quality to ensure universal health coverage. This health dialogue actually a platform where two-way communication for mutual benefit that actually initiated in Monpura, which is a southern part in Bangladesh, and coastal area where the road communication is very disrupted and people are suffering from to avail health services. So For Health Dialogue for Citizen, actually all kind of stakeholders take their presence to make a healthy dialogue or interactive dialogue to identify health service gaps and needs from that area. Many kind of people like community leaders, local government officials, public health expert, government health professionals, academics, journalists, students, or general people actually um, talk there about their understanding and to identify that gaps. This is actually a scaling up model of CJ model, which is a homegrown local level initiative. Chougacha Jhinaidaho model, which actually acknowledged by our government and is replicated in different areas to ensure that universal health coverage. According to Bangladesh National Health Policy, that public-private partnership actually acceptable to ensure that health services. So Health Dialogue for Citizen actually advocate those community people to involve to work collectively for that health for improving that health sector. Now I can talk on CJ model, which is working in hard to reach area. How? This model is actually working with the support of community people and local level, local influential people who can form a common fund for the poor community to avail the health service from the health complex, as well as for cleanliness to avail that other health services for all people. That collectiveness actually is required. So to ensure that collaboration, CJ model is scaled up in hard to reach area, and HDC actually to promote that collaboration was happened since 2016. When ICDDRB's share project started working in Monpura Upazila Health Complex with the collaboration of Directorate General of Health Services, DGHS, to working with local level leaders and government officials. First, when a team actually visited in Monpura to form community support group, which is acronymed by CSG. That actually community chaired by Upazila chairperson, which who is a local government representative, elected representative, who formed that community to ensure that health services through Upazila Health Complex. And afterwards, a health dialogue actually organized through that project in the Upazila Health Complex to ensure everybody's participation, to identify gaps and needs of that area, to provide quality health services among the community people. HDC actually helped to ensure that interaction between people and that service providers. That initiative actually consistently organized from 2016 to 2019, and that health service quality improved time to time after generating the reports after every health dialogue for citizen, as well as by media coverage. Several news campaign actually happened, and that advocate policy implementers, government officials from DGHS to avail the logistics and other services like human resource, as we can see in 2016, where medical doctors were 2, nurses were 2, and cleaners were 3. But after organizing those health dialogue for citizen in 2019, we can see that changes in HR, where medical doctors are 6, nurses were 16, and cleaners were 5. So this kind of advocacy actually happened by Health Dialogue for Citizen. This collective approach actually helped to sensitize the community people to understand about the necessity to visit Upazila Health Complex, which is a government hospital, and people can avail that services according to their need. So this customization, this customized health service actually availed by through that health dialogue for citizen, where people or government implementers actually understood about the uniqueness of that island area and how they can provide that health service to all. And afterwards, that health dialogue for citizen actually helped to ensure accountability of that community support group as well for sustainability. That is actually our health dialogue for citizen in the hard to reach area to ensure universal health coverage. Thank you.
Thank you very much, Nazrat. We'll ask some questions later. I was just thinking while you were talking, and I put it up on the poll as well, about whether we are adequately training our public health practitioners and researchers and health systems researchers enough on sort of development communication, health communication strategies, because so much of this work seems to come down to dialogue and communication capacities. At the moment, it's running even as to whether when I asked, are we training adequately, so far we're getting yes, not enough, and no. So we'll see, maybe as some more people vote, maybe we'll see if that changes. But I think that is the experience. So thank you very much. If you have any questions specifically for Nazrat, please do put them in the Q&A or note them down for later. I certainly have some questions with regards to how you handle issues of power dynamics in those kinds of settings. So do think about specific questions. The next presentation, which the slides are up in front of you at the moment, is from Irene Kayoni. Irene is a health systems researcher. She's working with Strathmore University at the moment, although she has a lot of experience in different settings. She was the recipient of a Wellcome Trust Master's Fellowship, and her research, I assume there, was investigating the influence of risk rating of health facilities on community engagement and accountability mechanisms in 2 Kenyan counties, which is what she's going to be speaking to in this presentation. I know there are other Kenyan colleagues that are attending this session, so it'd be great to get some of your ideas and experiences in the discussion forum. And I think it'll be interesting to consider the comparison between, because this sounds similar to a scorecard approach, so it might be useful to consider the differences between Irene's presentation and Noel's presentation in the beginning. All right, off we go.
Hi everyone, welcome to this presentation on do public reporting mechanisms like performance scorecards enforce accountability, which is a purposes evaluation of an innovative regulatory intervention that was done in Kenya. So accountability can be achieved through 3 pathways. The first 2 were proposed by Buckwick and colleagues. That's the selection pathway, where in this case the consumers become better informed and choose healthcare providers offering best services or high performing healthcare providers. And this acts as a motivation to the providers to improve their services so that they can attract more consumers and also protect their market share. The second pathway is the change pathway, where the healthcare providers make use of the information that they have been given to identify quality deficits. And from this, they are stimulated to be able to improve and better the services that they provide. The third pathway was proposed by Hibbard et al., And in this case, the providers work to improve the quality of services provided based on the fact that poor performance publicly reported may cause damage to their reputation. So in the Kenyan context, the Ministry of Health and the regulatory agencies developed a joint health inspection checklist, which was piloted in 3 counties, that is Kakamega, Kilifi, and Meru. The trial had 3 arms. The first arm had intensified inspections and a public display of the scores on a scorecard, which was ranked from A to D, D being the poor performance and A being the best performing facilities. It also had an intensified inspection arm without the display of the scorecards, and finally the control arm. So the inspections were done using a single comprehensive checklist on an e-platform done by one joint health inspector who would visit the facilities, do the inspection, generate a summary report, and come up with a score that was displayed in the arms that were supposed to get a scorecard. So the method, we did a qualitative study in the 3 Kepsi counties that I mentioned earlier, that's Kakamega, Kilifi, and Meru. We did a total of 114 in-depth interviews with health facilities, inspectors, patients, community representatives from health facilities, community health committees, and we conducted all this to just get a broad perspective from the community. The interviews were recorded, transcribed, and analyzed using the framework approach in NVivo. For the results, so with the change pathway, we got to see that the scorecards motivated the facility staff to improve because it served as a constant reminder of the recommendations that they had to implement. One of the public facility staff members told us that I think it's a good thing because it reminds you every day, it keeps you on the lookout at the notice board. You are like, I have a gap that I have to address. Also, the implementation team, that is the World Bank evaluators who were busy doing the monitoring and evaluation, noticed that facilities without scorecards were a bit hesitant to make improvements simply because nobody knew what scores they had. So for the selection pathway, we noticed that the scorecards were rarely seen by patients. On the few instances there were, those patients didn't understand. Not much dissemination information was done, probably because of the design structure. But then what we got to hear is that most of the patients were not able to identify it among other scorecards that are on the notice boards. So one community health worker explained that they just want to get to the doctor, get the medicine, then they leave. So it wasn't one of those things that actually just popped out for them to notice. And then for the reputation pathway, we saw that facilities with good scores were quick to show their scorecards, while those who did not perform well were eager to improve in the next round of inspections. The in-charges, as one national actor pointed out, were very quick to point it out to you. Sometimes, even if it was a poor score, they would immediately tell me that they were going to improve for the next time. And then what we also got to see was that the presence of a scorecard, especially at adjacent facilities, would trigger competition among facilities, mostly the private facilities, whereby one would want to protect the market share. And so they would want to have better scores than the next door facility. In conclusion, we think that rather than directly trying to influence patients, it could be better to add something to the whole intervention. So engage with community representatives, such as the community health workers and health facility committee, because they do have a say in how the community conducts its activities. And so once you engage them on the inspection results, they're able to push for change. And also dissemination, have dissemination and discussion about the inspection results. This helps in getting stakeholder buy-in and also just generally helping in improving the facility quality, the quality of services provided at facilities. Thank you.
Thank you very much. That was very interesting, and again, another example of a scorecard type approach. with some similar messages coming through about the importance of engagement and dialogue, and to ensure that those mechanisms work. And again, we'll have further discussions on that later on. I did put a question on the poll, which I'm not sure is a very good question, but maybe some of you might be interested, those of you that know about the Kenyan context. I've been wondering whether the Kenyan policy context is particularly open to listening to community voice than other health systems contexts. It seems to me that sometimes the policy and contextual kind of framework that is there for community engagement seems to be quite robust. I haven't had any responses yet, so maybe the question is not clear, but we'll see if there are any responses there. We're moving on to our second last one, our fourth presentation, and this is by Mrs. Patience Mgoli Mwale. Patience is a learning and advocacy manager with Care International in Malawi, and Patience has vast experience, many years of experience in social development issues and social development specialist. She's passionate about social reproductive health issues and gender equity. Patience wanted me to stress that this is a joint presentation between herself and her colleague, Mr. Chris Chinkanta, who is a, just make sure I get this right, Learning and Advocacy Technical Coordinator, also with Care International. So we've got Chris here with us as well, I think, so hopefully there'll be some discussion later. All right, Patience, let's move on to your presentation and then we'll have some chats later on.
Thank you, Jill. I hope you can see my presentation. Good morning, everyone. Sorry. Good morning and afternoon and evening everywhere you are, wherever you are. I know times are different in each and every context. That's the world we're living in. And thank you for joining us. I'll be sharing with you some of the learnings that Care Malawi has been working on around social accountability, basically engaging political forces and youth specifically. Our focus has been on the youth. As I said, we are working on a context where youth are taking up social accountability approaches and are becoming champions of some of the work that CARE has been doing, which is Community Scorecard, to raise voices and hold local governments accountable. Just to take you back in the context, CARE has been working for more than 2 decades in research and application. And within that context, I think the learning that's coming out is social accountability approaches help bring citizens and governments together to improve health programs and outcomes. CARE's greatest learning within this context has been around sexual and reproductive health, more special maternal and newborn health, and in the nexus of our social accountability. And this comes by using the community scorecard process. This process, basically, just to bring you to speed, is basically people or service users, which are community members in every context, who are engaged responsible power holders like healthcare providers or any other sector that you want to engage in. But as I say, that the nexus that brought this learning is within sexual and reproductive health. These healthcare providers together with the government officials to basically identify rights violation or service gaps and implement monitor joint action plans. As you can see from the from the pictorial on the right, the process basically is a staged process that brings in that goes in phases, but basically community groups assess and score problems, having planned together and prepared. And separately, service providers will be doing the same process, like in a phase 2 and phase 3. Basically, we will identify an issue, assess it, and come up with perception-based indicators. And then from there, these 2 groups will merge in an interface meeting where communities, service providers, and government officials come to discuss their different perspectives. From then on, joint action plans for implementation and ongoing monitoring for mutual accountability takes on. And this basically is a cycle that's repeated every 3 to 6 months. Some of the results that has come out of that context is that we've seen 57% increase in use of modern contraceptives. And secondly, the youth who organically adopted the process. And this is the basis for our evaluation. So within that context, we found that youth organically adopted the process, and 2 years down the line, they continued implementing the process. So basically, youth were conducting the process at micro level, and they were using the community as a unit of analysis. They were generating information through focus group discussions and interactions, similarly to the community scorecard process. And basically, they were allowing maximum participation of the local community. And immediate feedback was provided by providers and various stakeholders within that context for immediate response and joint decision makings. And action plans were developed within that context. So what did we learn from our study? We came in as part of an evaluation to evaluate the sustainability of the community scorecard process in the district where we're working in. So as part of the larger evaluation study, we conducted 8 focus group discussions across 5 health center catchment areas with 109 youth participants. Youth participants who had organically adopted the community scorecard process. And within that focus group discussion as an evaluation post the implementation, we had audio recordings that were transcribed and translated in English and then coded in Didos, basically using a prior code book that was used based on imaging codes and constant comparative approach. Themes that illustrated direct participant quotes were identified, and they were the basis now that we used to evaluate and see the sustainability and how the youth adopted the process. Some of the outcomes of this study, as I said, this youth piece was part of the larger evaluation study. From the youth piece, what we saw was all the 8 youth groups were still using the community scorecard over 2 years post-intervention, despite having received little formal training in the process. These youth basically were part of the initial intervention, the SRH intervention, but because they understood and contextualized the process and internalized it, they started implementing it outside the sexual and reproductive health context, and then started applying it in other contexts. And also they had little facilitation skills. I mean, they had minimal facilitation skills during the intervention, having only limited support from care post-intervention. So basically the skill set that they had was gained during when care had the intervention on the ground, but post, they continued applying the community scorecard on their own. As I said, the maternal health was initially focusing on the scorecard in Cheo, and yet the youth applied the process in thematic areas like child marriages, student rentation, and trying to understand and identify issues around natural resource conservation. So they began to train one another in the process, although they did not request any formal training from any service provider or from any organization like CARE. Basically, they took some of the learning out of the context initially, and 2 years after, they continued to improve outcomes using the community scorecard and child marriage, student retention, and natural resource conservation. And the youth reach, basically, as we said, the 109 youth trained each other basically on the process, having learned from the previous experience. And working with UNECO Helper. UNECO is a local organization that has got a radio station plus responding to issues to do with child marriages. In the social welfare office, the youth were able to rescue a number of children from early and forced marriages. Their understanding and their context in trying to iron out issues basically was understanding to say the community scorecard empowers you to understand what are your entitlements within this context and how do you move about engaging government officials to end issues that are emerging. So not many child marriages cases were reported in courts, and the community scorecard ensured follow-up referral linkages when such issues were occurring in the community. And in 2019, the youth convened a multi-country meeting to consolidate their ask on what it means to meaningfully engage them. From that, a product of the product that came in was a communique, what it means to meaningfully engage them. And basically the genesis is the community scorecard process that empowered them. They also, some of the results that came out also is that they recommended scale up of the community scorecard nationwide so that others can benefit from and champion the process. And also through our implementation experience, integrity, the integration of community voice in health planning and implementation, strengthen health outcomes. Basically trying to understand the context in which you're trying to program your work is necessary. Do not operate in assumptions to say, I think the data or stats is saying this, therefore we need to do this to improve the stats. For example, maternal deaths are XYZ, and then we need to do this to improve on maternal deaths. There are so many dynamics around those maternal deaths. The community voice also matters in that context. In conclusion, I would say that the study highlighted barriers and facilitators of sustainability. As I said, organically, the youth had picked up the community scorecard process, which enabled them to highlight and prioritize issues within their communities. And the diffusion of this approach among the youth enabled them to use their voice and facilitate a process where they are holding local governments, village leaders, and service providers accountable for their actions and qualities. And also looking forward, the youth basically are kind of future leaders. The community scorecard empowers the youth to lead by example, enhance governance and accountability. I have to say thank you so much for the audience. And my colleague, I think, was having connectivity issues. So that's why I had to go through it all alone. But thank you to my colleague, Chris Chinkota, who really was on the ground trying to facilitate some of the learning from this. Thank you so much. Over to you, Jill.
Thank you, Patience. Thank you very much. Yep, we might need to take a few of your minutes from the Q&A, but thank you. That was very interesting and interesting work in going on in Malawi over there. Right, so finally, we have Ms. Rana Saleh. I'm going to jump right into it because I want to leave some good time for discussion at the end. Now, I have to just comment that Rana is living in Canada at the moment and had to get up at 3:30 this morning to be here with us. So we really appreciate that. We know finding a time zone that suits everybody on the globe is very difficult. And I think Rana got the short end of the stick on this particular presentation timing. But Rana is an advocacy and evidence lead specialist. She was the lead specialist at the K2P Center, where she led the advocacy and public participation arms at the center. She's currently a PhD student at McMaster University, and she's also apparently a commissioner for the WHO UNICEF Lancet Commission for Future Child. And Rana is going to be talking to citizen engagement models in relation to prospects for responsive, inclusive, and accountable healthcare systems. So I don't think this one's specifically about community scorecards. I must just comment that there haven't been a lot of questions in the Q&A as yet. I know many of you that are the participants. I might start naming and asking you specifically, because I know many of you have lots of experience in this as well. So please do start putting some questions in the Q&A while Rana rounds off the final presentations. Rana, off you go.
Greetings and thank you for joining. I'm Rana Saleh, a PhD student at McMaster and a former advocacy and evidence lead specialist at the Knowledge to Policy Center at the American University of Beirut. Today, I will be discussing the importance of engaging citizens for a responsive healthcare system and the health system in general, and how to contextualize models for such an engagement process and the key features to ensure an effective contextualization process. I declare no conflict of interest. So why engage the public? Basically, it's their right as per the Al-Ma'ata. Sustainable Development Goals later came and ascertained the importance of realizing such an engagement process and such rights, because also it leads to the development of policies and programs that are sensitive to their needs, priorities, and expectation. It increases their trust in the system and empowers them to hold the system accountable and ensure transparency and better outcomes and services in the health system. In fact, all countries in the global north and many countries, in fact, have moved forward to social inclusion and public participation in the decision-making process. However, the Arab country lags behind, even though given the current context, it's highly needed. Lebanon is not different. However, in the recent revolution in October 2019, the Lebanese citizens asked for a better and an accountable system that engages them in the decisions affecting their lives and also their health. And as such, if you want to engage the Lebanese citizens, the models available out there from the literature and from the high-income countries does not apply to Lebanon. And if you want to scan the literature for available models for citizen engagement in our context, they're almost non-existent. And as such, we aim to develop a contextualized model for citizen engagement in health policy and decision making through scoping the literature of available models, and then adapting a model through semi-structured interviews with key stakeholders such as policymakers, researchers, media, civil society, and also focus group discussions with citizens themselves from various backgrounds and socioeconomical levels in order to identify different factors that they believe are important for their engagement. And then the last phase was a piloting of the model in order to reach to a final contextualized model. The contextualization process, in fact, that we are arguing of its importance, starts by understanding the current models available out there and understanding the current situation of the citizen engagement in Lebanon. And as such, identifying all the barriers and facilitators for an engagement process at all levels, and then adapting those models to what works in the Lebanese context, piloting, evaluation, and finalizing of the model. The results of our contextualization process identified the Lebanese as end users of policies. In fact, there are no laws and policies that mandate citizen engagement in the decision-making process as a whole, or even at a health system level. Any engagement process that are taking place are in fact not based on evidence, non-extensive, tokenistic, and limited to consultations with experts. The most important key feature of identifying a contextualized model is identifying the barriers of public engagement. In Lebanon, those were the dysfunctional and top-down policymaking process characterized by continuous political turmoil, weak and corrupted Lebanese systems and institutions, lack of accountability and transparency. In fact, citizens believe that there is no culture of engagement by itself, and that has been systematic over decades, where citizens fear to voice out their opinions, and also they don't believe if they voice out their opinions that those opinions will be taken into consideration. There is a wide and recurrent mistrust in the system. There is a limited self-agency and self-efficacy for change, limited awareness, skills, and health literacy. And if we want to engage them, in fact, there are no known processes and platforms for such an engagement process. There are no guidelines and protocols and no platforms and channels for such an engagement process. And institutions working in health policy are not ready or nor have the capacity to engage citizens. So if we want to address those barriers, the facilitators are as following based on our results. In Lebanon, we have to work on implementing system level changes such as democracy, decentralization, having a better election process, better policymakers who care about the citizens' values, developing contextualized models and processes with clearly defined engagement activities, launching formal platforms, and then contextualizing those models with citizens themselves. And if we want to enhance the knowledge of the citizens and the skills for an effective and constructive engagement, then we have to build their self-efficacy and agency, train them on their rights and skills for an effective engagement, and enhance the active citizenship in collaboration with different parties, such as having programs in schools and universities to enhance the citizenship processes. This is an example of the model that we adapted. So this is only one snapshot. For example, the sampling available in the literature was based on purposive or random. In Lebanon, we cannot use random because the last census made in Lebanon was in 1930s, and there is no sampling frame. As such, we can only use purposive per governorate going through a gatekeeper such as the municipality or the primary healthcare center. And the last phase was the piloting phase, where we chose one of the models, one of the activities identified in the model, such as citizen consultations. And that was done on the issue of school policies for childhood obesity prevention. We followed every single step of the model that was identified from our study, and that includes exclusion criteria, sampling, recruitment, models of communication with them, and the engagement activity was based on 2 days. The first day was to enhance the skills and knowledge of the citizens on the topic itself and on their rights of being engaged and how to be engaged in an efficient, in fact, engagement process. The second day was to discuss the policies and to contextualize the school policies for obesity prevention and validate those policies. Unfortunately, we were not able to implement this piloting phase due to COVID and due to the Carrot Lebanese revolution. However, the outcomes were very clear throughout the entire process that we reached. As an outcome, and I conclude here, the take-home messages is that we should not only focus on model features that are very important and very legitimate to look after. However, we have to look at all the other factors that would affect such an engagement process. So, for example, the model features should take into consideration the goal of the engagement, methods of the engagement, inclusion-exclusion criteria, sampling, recruitment, modes of engagement, how to use the outcomes of such an engagement activities, and understanding the barriers and facilitators. However, these are not effective alone, and what you have to do is to work on the institutional readiness and capacity for such an engagement activity, build a culture of engagement and trust in the system through multiple activities, and enhance the system readiness and capacity, and allow for laws and policies that mandate citizen engagement in the decision-making process. Really, those all together are the key features to ensure a successful citizen engagement activity that enhances the inclusiveness and responsiveness of the healthcare system, not only in Lebanon, but also in any other context. Thank you so much for joining, and that's it for today, and we will be glad to take questions whenever allowed.
Thank you very much. That was great. So those were 5, I know it was a lot to take in, and it was 5 presentations, one after another, and it's the start of the year, so we all need some time to digest. So five quite similar types of interventions and intervention experiences, which is why they were pulled together into this panel in very different contexts, but some similar messages and themes coming out across all of them. I am not seeing a lot of questions, so I'm going to start posing questions to the panel, and we're going to go from there and see if there are others that pop up from the group. The first thing, and I did warn my colleagues that I was going to do this. I think the first question I'd like to really ask is, based on their experiences, and we'll just do a round and see if there are any quick responses. But based on your experiences, if you can extract, what were the main enablers or barriers for amplifying community voice? Because I think very often as researchers and as practitioners, we often say things like, there was dialogue, or but if you had to extract from your experiences, what were the main enablers that amplified community voice, and what were the main barriers to seeing that impact and getting that right? If you have a quick answer, and maybe we just go in the order of the presentation and just see if there are any responses. I think the panelists can all unmute and put your videos on if you want to. Noel, do you have a response to that? Let's start with you. It's been a while since we heard your presentation.
Yes, I'm there. Thank you all for those wonderful presentations. One of the facilitators to amplifying community voice is capacity building. If you build the capacity of the community, you train them, you let them know of their rights, of their roles, as far as service delivery is concerned. I think that's a critical one, a good one. And then one of the barriers that we noted is being on. Let's say they demand given services, they raise this concern, and if you don't respond to that, that demoralizes them to even engage. So we need to ensure that whatever community is raising, whatever they are requesting, whatever services, action is taken on that. That's a quick answer I could give. Jill, over to you.
Thanks, Noel. And just to let everybody know that Noel did confirm earlier that he was having some internet challenges, so he broke up a little bit there. But I think we got the gist of what you were saying. Nazrat, you come from a communications background. Would you agree that the main enabler is to strengthen capacity in the community, or would you say that you also need to strengthen capacity on the side of the health system, within health professionals, health workers, for dialogue?
Yeah, actually, I would like to add that it will be a holistic approach. In both ways, we need to be very proactive to make that dialogue successful or effective in the community, especially where there is like very limited facilities, hard to reach area, for example. So yeah, most importantly, community have to get that positive approach to consider it as a very effective tool, as well as the policy service holders, as well as the whole system need to act like more effectively to consider that inclusiveness of community. Yes.
Thank you, Nazrat. It's nice to hear the background noises from Bangladesh as well in the background. It's always nice to get a taste of things going on.
I'm managing this. Sorry for that interruption.
I love hearing the traffic in the background. So Irene, then just following up on that, I mean, when we took the little poll about, do community scorecard approaches work? Most people said yes, they're useful, but some people did say it's difficult sometimes to see the impact. Based on your experiences, would you say in Kenya, what would you say are some of the main barriers to getting it right, to getting the voice of the community into the systems, policies, and health practice processes?
Thank you so much, Jill. So according to what we found from the study, it was an RCT. And so because of its nature, they didn't do much dissemination of information. And so that really did hinder a response from the community, because it was really hard for people to identify the scorecards from other posters that were in place in display locations. So I think better dissemination, better communication, and just having the public understand what the scorecards are meant to deliver, the message meant to deliver, would really be helpful.
Patients are staying on that theme. I mean, you work with Care International, which is it's an NGO, it's an external body. So in a sense, there's almost like a triangle really between community, health service, your organization and the actions. I mean, would you say that is an enabling factor to have external partners involved with that as working as facilitators? Or would you say that sometimes creates other dynamics that need to be managed in terms of developing community voice?
I would say it acts as both in that context. What we've learned over time is that sometimes international NGOs like CARE, they are placed like we tend to bring in novel or foreign ideas, and they're branded as foreign because communities would say you want to push things to us. That's a barrier. That's the biggest barrier, I think, with international NGOs. However, within that context, I think because you are an international organization, the experience, the vast experience that you've had in working in various contexts enables you really to maneuver in difficult terrains, hard to reach areas as well. Hard to reach areas as well. Hello.
Sorry, I think we lost you there for a moment, Patience. So sorry, I carried on talking. Did you want to just finish off a thought?
Yes. So as I said, there's an international organization in the same context. It also acts as an enabler in the sense that I think the vast experience that you learn from other contexts.
Okay,
it helps you to quickly adapt, and in resource capacity, I think it helps, and the communities are able to use you as a mediator whenever there are community dialogues or community engagement. So it's easier for you to be an external, like a mediator, and not be engaged between the discussion between the communities and the providers. So much so that at least you reach a compromise at the end of the day without being involved or without being entangled in the process.
Right. Sorry, we're having a little bit of an internet instability between us, but we'll persevere. Nazrat, sorry, just to complete the train of thought. I mean, any specific enablers or barriers? You know, I suppose what I'm trying to kind of push all of you, 5 of you, into is less of kind of general ideas such as, you know, more dialogue and capacity, but like really specifically, can you think of enablers and barriers that were specifically relevant for in your context?
In Bangladesh, mostly when we are talking about that very hard to reach area, specifically where the women are actually in the backward and are very unheard voice of them. So there to convince those women to get forward and talk within that community, as well as make some interactive dialogue, that is actually a great barrier when we are thinking of some kind of this kind of dialogues, and when we are more focusing on women voice, women empowerment in the context of hard to reach area, where the illiteracy is like another challenge, and those people who are really depending on their male partners or the head of the families, they cannot talk much in the public about their health or other things. So this kind of barrier actually a main challenge when we are really intending to get their voice in the dialogue or the public platform. Yes.
Thank you, Nazrat. Rana, sorry, I lost you for a second, so I jumped over you. So I'm going back to you to give you a chance. In your context, quite a different context to the other sub-Saharan African and the Asia Pacific region. Enablers and barriers, or would you support what the others are saying?
I do in fact support what the others were saying, but mainly the main barriers that were identified in the Lebanese context, and it was so clear in every single focus group, in every interview that we had, and it's the trust in the system. We had a lot of hard time finding people who were willing to engage with us in those focus groups about those previous even citizen consultations that we had in Lebanon, just because they did not really trust that their voices will be heard. And they were so bored with all the research that they don't see outcomes of. And that was the main challenge. And then once we engage with the people, the one main barrier was that they really don't know their rights. They really don't know how to be engaged, what channels to be engaged, and how to be effectively engaged. So just in order to establish the rules of the dialogue during the citizen consultation, we faced a lot of trouble. And as such, the enablers here, and I've shared that in my presentation, are at so many different levels. But I believe that one of the main features would be to have platforms who are dedicated to be a point of junction between the communities and the system, at least when you are first introducing citizen engagement in a country. those platforms should be training citizens on how to be engaged, and inform them about their right to be in fact engaged. And then those will facilitate reaching those voices into the system level factors, and in order to ensure that their voices are in fact heard.
Thank you, Rana. That actually, it's a good segue into my second question. I think we have time for one or two more questions. I might not do the whole panel, but I was interested in, I think, if I could remember correctly, Irene and Noel, both of you used a quasi-experimental approach, I think, if that's right. I suppose what I'm trying to think of, this is a conference in health systems research, so not only the practice, but also the research of the practice in relation to the practice. And I suppose I wondered, my question is, in terms of your experiences of doing research on this topic and this kind of work, what, in your experiences, are the best practice ways of conducting research to see the effects and impact of community accountability interventions of this sort? Because I think very often it's quite difficult to do that work. And Irene, I think you mentioned a quasi-experimental study, and I was quite interested in that because I think, as far as I know, there's only one or two other published studies that show a more kind of fixed approach to evaluating this kind of intervention. So sorry, that was a slightly long question, but I suppose I'm interested in the research approaches on this topic and your best practices, ideas, thoughts, experiences, advice relating to that. Irene, I'm just going to start with you just because I remember you mentioning your research approach, and then I'm going to go to Noel, and then I'll see if the others have a comment on that. Any thoughts in relation to the research approach?
We did a qualitative study, and we had to make it as broad as possible to get to engage with the community. So I think majorly just building information and getting research and data from the ground, just being able to communicate with the people, the patients, the people at the facility, and then getting a much broader perspective from now people at national levels. The representatives from different registration council really did help give us a broader perspective and a better understanding of how to best understand the implementation, because ours was a process evaluation. Okay,
so it was a mixed method, mainly qualitative process evaluation, and that's totally understandable. So yeah, and you found that worked best for what you were trying to do. Noel, yes. Was I right? Was yours more of a fixed type of a quantitative type of approach? Noel, are you muted? Okay, I think we might have a Ugandan internet connection challenge. Any of the others? Rana, did you have a particular advice in terms of researching this topic?
Well, when it comes to Lebanon and context that they don't really engage public before, then all research is warranted, whether quantitative, qualitative, or mixed methods. But at least for a start, then definitely qualitative, because it will enrich our experience and what the citizens want and need. And that was, in fact, what influenced our work in the model and what identified the key features that they believe should be available in those models for public engagement. So they themselves identified how they want to be engaged, what were the methods, the channels, the processes that they believed worked for them and was easy for them to be engaged with.
Great, thank you. Noel, I'm just seeing if you're back with us. No, I think he's struggling to get on. Sorry, I'm going to keep going. No, there you are, right.
Hello.
Yes, Noel, I'm giving you the space. I want to give you the time because I want to just make sure that you have a chance to speak. Any thoughts on this matter?
I didn't get the question.
Okay, so we're asking about your best practice experiences doing research. We're looking at research experiences in terms of this topic. Okay, Noelle, I think your internet connection isn't strong enough to hold the dialogue. I'm going to type the question to you in case you want to respond in writing. Patience, you're more of a practice organization, but you do research. So what were your experiences in terms of, I mean, do you do, what kind of evaluation do you do on this?
So prior to evaluating the youth piece in terms of sustainability, we had an implementation kind of approach to evaluation. We did a randomized control trial when we were implementing the community scorecard. So our learning from that, I think the challenges, some of the challenges was because we're doing kind of implementation approach, the balancing to say, how do you have a control in the treatment area? At the same time, looking at issues to do with rights, entitlements, and how do you balance the two? So I think those were the challenges that we encountered. However, I think discussing with the local governments and the national governments, they gave us a go ahead to say, I think you can start with the treatment in one site, and then maybe 2 years down the line, you can roll out the whole treatment in the control area. So at least to balance the two pieces. So those are some of the give and take situations that we encountered along the way when we're implementing. But holistically, I think looking at the community scorecard approach, to some extent, the approach itself already is more kind of a study, because you start with unearthing issues, and then from then you implement based on what have you agreed upon. So those issues are kind of, you're doing a research at the beginning, and then you move along the way. So it's an enabler as a process, but at the same time, I think the challenge in between is you have to balance what the expectations to say this is just a study and we're limited according to this. Beyond this, we cannot address, maybe engage the government, engage other CSOs, engage XYZ to address those issues.
Great. So we only have a minute and a half left, and I don't feel the need to do a long wrap up. So maybe I just thought I would just double check with the panel whether anybody has a last comment. It would have to be a brief last comment, I'm afraid. Rana, let's start with you because you're at the top of my page. Any last thoughts on this matter, that ideas for taking this work forward?
Thank you. Actually, all the discussions were enriching, and I don't have any other further comments.
Perfect. Irene, from you? Last shout out from you?
I just saw a question from Nancy Kagwanja. She wanted to know if there were any resistance when dealing with health managers and providers. And I think if they are taken through the whole process, if it's an inspection process and they're part of it, there's minimal resistance. That's what I just want to mention in response to her question.
Okay, thank you. I didn't see that question on mine, but maybe it came to you privately, so that's great. Nazrat, you've got a couple of seconds. Last thoughts from you?
I would like to add just one thing about that whole community-based approach to make that universal health coverage confirm is like we need to work cooperatively, if possible, to knowledge exchange hub, or if we can work like together with the other countries so that we can exchange our best practices in the other context, as well as exchange that knowledge with the whole system or health systems. That would be more effective in future. I would like to add that only. Thank you.
Thank you. Unfortunately, we seem to have lost Noelle entirely now. So Patience, last quick thought, a few seconds left.
Yeah, just to comment, I think the whole panel, and I think the rich learning, basically, I think when you look at the processes for community engagement, there are various methods. And I think contextualizing matters most when you're trying to understand the situation or situating your program within that context, whether it's research, implementation, contextualization matters most, and engaging the communities. Just to give a shout out, if you want to know more about community scorecard care, you can go at care.org. There is a website that hosts all the material over there. Yeah, thank you.
Great, thank you. Sorry, I'm sorry to cut you off. We just only have 10 seconds left to say thank you very much. Thank you to our conference room technical support. I'm going to say thank you from Noel because he unfortunately fell off and I know he wanted to say goodbye to everybody. Thank you to our participants. We didn't get a huge number of questions, but we hope that means that it was interesting and that you were listening. And thank you very much to the panelists for your work, for your thoughts, and Rana for waking up very early, and to all of you for being here. Thank you, everybody. That's the end.
Thank you.
Thank you.
Thank you. Bye.
Bye.
Bye.